We will now move to the UK, and Matt Southwell is Managing and Technical Director for COACT, Technical Support Limited, and deliver technical support about and with people who use drugs in humanitarian aid settings. Matt is part of the first generation of harm reduction workers to respond to HIV among people who inject drugs, and he founded the Healthy Options team, HOT, in 1991, and went on to lead East London and City NHS drug services. This included a dynamic partnership with local GPs and a pioneering shared care or opioid agonist treatment scheme that engaged some of the most marginalized people who use drugs in healthcare. Matt came out publicly as a drug user activist on a BBC TV documentary in 2001. Since then, he has worked in the drug user rights movement from the local to the global. He's half-time project executive for the European Network of People Who Use Drugs, Euroinput. Matt, the floor is yours.
Thank you very much. So in fact, I left Euroinput in just at the end of March last year, and very happy to hand over to my friend Alexei Lahov, who is now the half-time executive director of Euroinput. So that's leading me to be able to focus exclusively on COACT, which is a community-led technical support agency. And we try to take, we do take the expertise of the drug user rights movement and share that through technical support in international development settings. So firstly, let me acknowledge the incredible range of speakers that we've had in this session. Really great to share the floor with 3 countries that I've worked in and colleagues who's describing really important work that is really now making huge differences for people who use drugs on the ground. So firstly, I'm sad to have to acknowledge that someone we had just appointed as our first COACT consultant in Africa died yesterday before he'd even actually been able to start work for us. Bala Majiji was a key figure in Youth Rights Nigeria, a key drug user activist who was in part of the 2019 implementation, and really a very sad and unexpected loss from a chest infection, which really just highlights how vulnerable healthcare systems are inaccessible for people who use drugs, particularly those without healthcare insurance. So dedicating this presentation in the memory of Bala. So I'm going to talk more about the Unitaid study that Annie Madden referenced at the beginning of this project, and I think you've already heard that the Unitaid study has been a really critical vehicle for demonstrating how we can involve people who use drugs, from the creation of community advisory boards, but really all the way through as key actors in the research gathering process, the research analysis process, publications, the wider knowledge management activities. And really, rather than sitting there, questioning whether people who use drugs have the capacity to take part in studies, we're really using, it's coming from a place of saying, how do we help people who use drugs take part in research studies? And we're seeing people from communities across the 10 sites stepping up to demonstrate the value of this process. And this model that Annie Madden has been really key to championing, this values and preferences model. We previously supported the implementation of needle and syringe program in Nigeria in 2019, one of the first countries to really systematically try to implement needle and syringe program through community-led organizations. And we tried some of the early work to ask people who inject drugs what needles and syringes they would like, and while that was a very informative process, it didn't quite stick in the way that we wanted to. And the values and preferences research model really starts to frame this process of participative development within a strong research frame that is already impacting on the way that needles and syringes and other harm reduction commodities are pioneered around the world. So during this presentation, I'm going to use some pictures made by Mathieu, who's a French cartoon maker who works with us each year at the INSU Community Day and has been doing these series of portraits for us of different CAB members. So the first thing I think that from what Annie shared was the role that people who use drugs have played in the selection of needles and syringes and will play in shaping people's understanding of long-acting depot buprenorphine. So this real technical model of being involved in selecting needles and syringes. And while Annie and I selected a sort of core starter kit for people to look at on the study, now you quickly understand that different countries have different needs. People are using different drugs. Now in Ukraine, for example, needing a 20 ml syringe because of people using and filtering home-baked drugs. People in Egypt needing to look at having access to cookers and acidifiers because they're using brown heroin. And then potentially also in Ukraine needing access to more sophisticated filters because of the use of home-baked drugs. So really detailed interaction around the commodities that people are being used and really bringing in community-led technical support, but also really deploying that country expertise. And there are 3 different consortiums in the Unité project, one led by Médecins du Monde, which Input is supporting, another led by Frontline AIDS, which COACT is supporting, and then PATH and PSI working together, and which I'll talk about more, how we're supporting them a bit later. But PATH has developed this very interesting model as a country level of having very robust country community advisory boards, both in South Africa and South Africa and Ukraine, as illustrated here, and using those community advisory boards as a space to really teach people about protocols, guide people about how to do peer-based research, skill people up around technical aspects like coding and research analysis, writing focus group reports, having facilitated them, really skilling people up through these forums, through these spaces. Now, PATH has the advantage of working with a number of countries that have got quite well-developed drug user groups, and that's really supporting this model of really building the capacity of people on the ground. Now, the Frontline AIDS Consortium, we're very fortunate to be working with Dr. Ragda and the many excellent colleagues in Egypt who are really driving forward this presidential initiative on the elimination of hepatitis C. And we're very fortunate as people who use drugs that key leaders like the Deputy Minister of Health, Dr. Husseini, and Dr. Ragda have really recognised the need to address harm reduction. WHO have been very influential in understanding that if you want to achieve full hepatitis C elimination, you have to tackle the concentrated epidemics among people who use drugs, people who may be using stimulants, people with opioid dependence, looking at how we respond and engage those different populations. And look, Egypt's services have traditionally come from much more recovery backgrounds. The staff have been trained through Narcotics Anonymous or Minnesota type models, but really enthusiastic partners who want to learn about harm reduction, who are skilling themselves up, and particularly as we start to see the new generations of people on OAT from Egypt coming up, that will give us a whole new generation of activists who can start to contribute to building the political health capital of people who use drugs, so we can be full and meaningful partners in harm reduction and also in our own drug treatment. And we know that leads to far, far better outcomes when people are able to define their own treatment goals and match their positive change to their capacity, their circumstances, and their life goals. So let's look at some of the other things that we've been doing within this project, because it's not just about consultation by any means. We have really robust client materials, so working with a community-led designer and a Theoraka from Greece, has been working with both Input to develop the resources on low dead space needles and syringes, working with PATH and COACT to develop resources on long-acting buprenorphine, and earlier working with Frontline Aids and COACT to develop a whole new safer injecting course. So really powerful, comprehensive resources designed to be translated. So you can see here on the right, 3 of the resources that have been translated into Swahili, Armenian and Georgian for the MDM project, but each one is adapted and developed as part of this model, which also has the advantage of creating really good quality resources that could be deployed more widely. We're definitely going to be running the Safer Injecting course as a Train the Trainers course so that we can share the development work beyond the Unitaid projects to maximise impact. Now, people who use drugs on the ground, particularly if we're trying to engage those people most involved in the front lines of taking drugs and also in the front lines of the peer-led harm reduction response. Now, some of those people, there are exceptional people like Annie Madden who have this wonderful capacity to be both drug user activists and to have this huge research capacity as well. Not all of us have those skill sets, and particularly people may be working on the front lines of outreach, but that doesn't mean people can't be skilled up and taught how to play those skills. And this slide here shows you on the left the Frontline AIDS led process in the Innovate Involve Inspire consortium, the C3I consortium. Frontline AIDS providing the sort of research support, the overarching organisation. COACT being a community-led technical provider. DAPO, our local Gombe State Nigerian partner, having the outreach team who are learning how to recruit for the focus groups, run the focus groups, do the note taking, do the processing. And then we were also bringing in partners from my old workspace, the European Network of People Who Use Drugs, where our peers from Norway and Portugal were sharing their experience of doing point of care testing, which now is going to be implemented in Nigeria, where DAPO have their own genotype machine to really do point of care testing through to the point of initiating treatment, working in partnership with the Gombe State Hospital. And the other consortiums have, of course, have had their own processes of facilitating and building the capacity of people who use drugs on the ground. On the right-hand side, you can see Annie Madden leading a parallel process with TAMPUD, the Tanzanian network of people who use drugs, who themselves are also running their own studies around low dead space needles and syringes. So understanding, yes, a common process, yes, common standards, yes, common principles, but understanding that by involving country community partners, we get to make sure the response is really tailored and nuanced and resources are most effectively spent and deployed. And then working with our partners in the PATH consortium, both Input and COACT shared the frontline training that we have been doing and sharing skills between the consortiums as we supported the trainers of the teams working in the PATH consortiums. Will benefit back from the PATH consortium who are leading the LADB study and will be facilitating that process of learning from their lead project area. It's a very collaborative model. And then our community advocates, this is Alexei Kmitsky from Ukraine, the first person on local long-acting buprenorphine from Ukraine, a really key advocate, really helping us think about how we design treatment, how we manage issues like titration and redosing. Here speaking at the World Hepatitis C Summit as a key advocate for using opiate agonist maintenance treatment as a methodology to help people comply with hepatitis or adhere with hepatitis C treatment. And then at the same time, we've been each year at the INSU conference, there's been a feedback process from the in-person community advisory board that meets each year. Critical that people come together and meet each other, interact with each other. That helps us keep working through the quarterly meetings across the year. And then there's a feedback process into the community day that takes place at Inshu. And I know my partners in Input are now ambitious to do even more feeding back into the Inshu program. And then just the last two slides. Just coming to the end now, we're also looking at how we share knowledge from the program. Yes, the hard science is very important, but we're also looking at other innovative ways of sharing knowledge. You've heard me and Annie speaking from the program here today. Angela from South Africa will be speaking at an Input side meeting later during C&D, and you'll be hearing Violet during the panel. So we're coming into these spaces, sharing our experiences, also using innovative social media stories like these blog posts of Anidi, our Nigerian lead partner. Input is setting up a new website so that the information from this critical study continues to be available both during and after the study, so that other partners can take the resources, take the learning and apply it within their own work. And then we're helping as COACT to document key technical practice, pick up good practices as we're going along, and support this critical process of dissemination to governments, to the community, to partners, to providers, to academia. And finally, just let me finish on a quote from our Ukrainian CAB member, Vyelta Parmenko, we asked people to give feedback about their experience of the CAB, and I think we all agreed that Vyelta really nailed it in this statement, that the Unitaid CAB stands as a true model of how community leadership makes health interventions more effective, sustainable and ethical. It's not just about inclusion, it's about shifting power to those who best understand the problems and solutions. Thank you.
Thank you, Matt. That is indeed a wonderful quote. I would love to copy that at some stage.